So thank you, John, for inviting me, and thank you to the organizers for inviting me. So I debated already yesterday with Bruce Chesson and obviously lost, but today I know my opponent since this morning, and I work with him every day, so this is a debate we have often, and I kind of anticipate what I'm going to hear. So John will tell us that we have to do watchful waiting, that's a reasonable option. He will tell us that we need to use these novel agents, that they have high remission rates. He will tell us that autologous transplant is quite toxic, that it's often not great, and that it's not effective. I will preempt these points and will try to convince you, or will convince you otherwise. Watchful waiting reasonable, and this is based on, I will convince you that watchful waiting is often a short time of waiting, and it's not very practical in the majority of patients. The data for this come from Peter, Martin, and John, and it's in JCO in 2009, and they looked at 97 patients with mantle cell lymphoma, and there were a third could be watched for more than 3 months, and about 7 or 8 could be watched for more than 12 months, and they did quite well. But again, look, 66 out of 97 were treated right away, a couple within 3 months, 6 months, the rest, very few 1 to 5 years. I really don't know how many were 1 year and how many were 5 years. I would argue that this is a small minority of patients where you really can wait for a long time, and we all know that there are indolent mantle cell lymphoma patients, but they're few and far between. And the major argument I would make is that at the time that this was being published, John was talking to me about coming to New York from Chicago. So why would you recruit a transplanter if you can watch everybody? So that's point one. Point two, novel agents. I'm sure John will talk about a lot of novel agents. We've heard about them all day and yesterday as well, and I think they're fascinating. But I will argue that the response rates in mantle cell lymphoma at least are low, remissions are short, toxicities occur, and progression and even transformation are frequent. And what are all the agents? This is just a slide, forget where I got it, but it's incomplete. This is not a novel agent, obviously, but bendamustine not so new anymore, but a variety of agents tested. Let me just talk about ibrutinib in mantle cell lymphoma. So from the paper in the New England, really only 23% complete remissions. So that's not a great, mantle cell lymphoma is a disease that needs a complete remission to have any meaningful benefit. Yes, 77% response rate, but of those with responses, this is 12 months. Half of the responses are gone again. And I could show you the survival curve, it's not much better. So this is an agent that works, but this is not an agent where you stop. If you give this agent, then you provide some temporary relief in some patients, but I don't think this replaces transplant. Plus, we've heard about atrial fibrillation, we've heard about bleeding, we all hear about the expenses. And my major concern is we're going to use these agents so much, we will lose an opportunity. And let me show you some examples. These are 2 real patients. A 56-year-old gentleman who had a long history of colitis, had his colon removed, and then during an exploratory laparotomy for adhesions, they find an indolent mantle cell lymphoma. This is one of the patients where it's very reasonable, low proliferative index, watchful waiting. But, you know, a year and a half, 2 years, his blood counts drop, his bone marrow gets involved, and his lymph nodes grow. He gets rituximab, Revlimid, has progressive disease, gets bendamustine, rituximab, has a partial remission. We mobilize him with chemotherapy, and now he's in an ongoing remission for 3 years, and he's back to work. So, you know, we'll argue. We are really not arguing. These treatments should be integrated. We are really arguing about the place of this treatment. Should we always move it to the last treatment, or should we move it more up front? And the second patient is also a real patient, a 70-year-old gentleman, had lymphadenopathy, peripheral blood, bone marrow involvement, developed constitutional symptoms, had bendamustine rituximab, and progressed on treatment. Not only did he progress on treatment, but he developed blastic mantle cell lymphoma. And that's my concern, because then he got hyper-CVAD, and I think he got semibrutinib already. And not only, yes, transplant is very selective, but we are actually very many times the least selective of anybody. We get the patients when nobody else can take care of them anymore. When nobody saw he was not in great shape, we got him with desperation in a transplant. We did a cord transplant, and he survived it. And he did actually well, but relapsed again 6 months after transplant. And I cannot help thinking, should we have come in here earlier on? Should we have, this guy with rather aggressive lymphoma? Would it have made a difference had we come in earlier? Transplant is toxic. Autologous transplant is not toxic. I think the toxicity is really related to delaying it too long. That's when it becomes toxic. And I will make a short argument that our quality of life could be better. The issue that John brought up a little bit ago, we are really lousy at saying what is quality of life, studying it. Is it the acute treatment within prolonged treatment-free intervals, or is the chronic exposure with all the anxiety of not being in remission and waiting for the next treatment and the side effects of the chronic treatment? These are myeloma patients. But just to illustrate, patients over 70, 33 patients, mortality at day 100, 1%. These days, I really, in the last 7 or 8 years with autologous transplant, with now a median age of 68 probably in our program, and in most programs around the country, treatment-related mortality is exceedingly low. In this time in the hospital, here they did outpatient transplants, and so do we. 3 days, a little bit more, but on average 8 days in the hospital. So this is really this, one needs to be equipped to do it, one needs to have a team, one needs to really be detail focused, but when done in an appropriate setting, it can be done in even older patients. Our oldest patient was 78, and other people have done, and she did actually quite well, unfortunately relapsed. What has determined in every study I've ever done of transplant, these are allotransplant data, but again, the best predictors again and again is the performance status and having chemotherapy refractory disease. So if we keep, and this is regimen-related mortality, and of course also progression-free survival and overall survival. So if we want to use this treatment, we should use it earlier. Quality of life, not aware of many studies, only one study in follicular lymphoma comparing autologous transplant with R-CHOP treatment. Quality of life, fatigue, nausea, pain, dyspnea. In practically every respect, there was more fatigue with chemotherapy, there was more long-term pain, more decrease in quality of life, and overall, in every respect, there was slight superiority for the patients who had undergone autologous transplant. So it's a fallacy to assume that what we do is always the most toxic. It's actually the most time-tested, and probably the treatment that has been most extensively studied. Autologous transplant is not feasible. I just showed you that it's feasible, even in older patients. And the only thing that may not make it feasible is decline in performance status and also excessive prior treatment. These are mantle cell lymphoma patients exposed to hyper-CVAD in this case. If you collected the stem cells after one cycle, you could always collect them. If you waited after many treatment cycles, only 18% of patients could mobilize stem cells. So if we are going to consider this treatment, we shouldn't send the patients to the transplanters after 15 treatments because they won't be able to collect them anymore. Maybe a little bit better nowadays with Plerixafor, but it remains an issue, and we may be forced to do an allogeneic transplant in such patients, which is much improved but continues to have serious morbidity and mortality. I think it's extremely effective. It remains the standard. And let me quickly show you some data. A randomized study now already older and before rituximab, autologous transplant versus CHOP-like chemotherapy. So they had 6 CHOP-like chemotherapies followed by 2 consolidations, interferon maintenance, or followed by an autologous transplant. One can argue no Rituxan, but I don't think that really should affect the interpretation too much. The impact of this on progression-free survival was quite remarkable, with at 2 years a 40% versus a 70% progression-free survival. In the days of rituximab, there are only non-randomized studies. These are 4 of them: the Nordic Lymphoma Group, MD Anderson, CLGB, the French, and the Italians. All of them progression-free survivals ranging from 73% to 7 years, 4 years 73%, 7 years, 5 years 56%, with excellent long-term survivals. Let me show you the Nordic Lymphoma Study Group, which is a combination of intensive chemotherapy, rituximab, stem cell mobilization, and autologous transplant. And here they show, and this the event-free survival in different groups, and they show that in the low MIPI scores, which applies to our patient, in the low MIPI score at 7.5 years. Now, we're not talking about 12 months, 14 months, which is where the ibrutinib curve ends up here, and that is in the New England. We're talking at 7.5 years, with lots of patients with prolonged follow-up. Progression-free survival is still 60%. So this is quite good treatment for these patients. This is tolerated treatment, this is good treatment, and if 30–40% of patients relapse, even though after prolonged treatments, they can still be salvaged quite well, and overall survival is remarkably good. So I would argue that autologous transplant is extremely effective, remains the standard. It has much more data behind it, both in efficacy and toxicity and in long-term follow-up than any other treatment. And I hope you vote for it. In truth, I think this truly is, these debates are meant to highlight the point, but I truly think it would be ill-advised to forget about this treatment. It's a bit of dogma that I hear. I'm just like you, I'm fascinated by the new treatments, but there's a dogma that new is better, and we call it targeted. We don't call it chemotherapy anymore, although we've never known that form, so we call it non-chemotherapy targeted treatment, and it's supposed to be better, but there's no drug that has no toxicity, and this goes against something well-established that admittedly is not perfect. And I think the challenge is to integrate these treatments and to not separate them from each other. With that, thank you for your attention.